Imagine you're in an emergency room, right? And you are just struggling for every single breath.
Yeah, a terrifying situation.
Exactly. So the EMT rushes over, and your first instinct, and probably everyone else's in that room, is to beg for 100% pure oxygen. Just give me the oxygen.
Right, that's what we've all been taught.
But what if you are a premature baby? Because if someone hands you that pure oxygen, it might actually permanently blind you.
Wow. Yeah, it's a completely different rule book.
It really is. Welcome to a new deep dive. Today, we are stepping into an environment that, honestly, most of us hope you never have to see. But it represents the absolute pinnacle of human ingenuity. We're talking about the Neonatal Intensive Care Unit, the NICU.
Yeah, we are using an incredible source for this. We've got an excerpt from Debbie Frazier's medical text, Nursing Care and Management of the High-Risk Newborn.
Right. And our mission today is to pull back the curtain on this intense, highly technical world. We're going to decode exactly how modern medicine, cutting-edge technology, and just expert nursing support the most vulnerable humans on Earth as they make this perilous transition from the womb.
It's a profound world to explore. I mean, truly, when you really get into the mechanics of this source material, you realize we aren't just talking about tiny babies in plastic boxes.
Not at all.
No. We're looking at this incredibly high-stakes intersection of physics, developmental biology,
Yeah.
and just sheer human resilience.
And the stakes, I mean, they really couldn't be higher. We're talking about a field of medicine that costs billions of dollars annually, pushing the absolute limits of viability. So let's just get right into the physics of it.
Let's do it.
What exactly makes an infant so high risk the exact second they leave the womb? Because in the text, they classify the risk mostly by weight and growth, looking at infants coming in at less than 2 pounds. But it's not just about being small, is it?
No, not at all. Weight alone is actually a pretty poor indicator of what's really going on inside. The text draws this crucial distinction between an infant who is naturally small for their gestational age, perhaps just due to genetics.
If they just have short parents.
Exactly.
Yeah.
Between that and an infant suffering from intrauterine growth restriction, or IUGR.
Okay, right.
IUGR means the fetus did not reach its biological growth potential because of some extrinsic factor, like a failing placenta.
Right, and here's the part that really stopped me in my tracks. The text breaks that growth restriction down into symmetric and asymmetric restriction. I am stuck on this biological mechanism.
Fascinating.
Right, if an infant has asymmetric growth restriction, their body weight basically plummets below the 10th percentile, but their head size stays totally normal. How does the fetus even know to do that?
Well, it's this brilliant, desperate survival mechanism. In an environment where resources like oxygen and nutrients are severely restricted in the womb, the developing fetus fundamentally triages itself. Yeah, the cardiovascular system will literally shunt the available nutrient-rich blood away from the body to specifically spare the developing brain. It sacrifices somatic or body growth to protect the central nervous system.
Which is incredible. But then you have this tiny, fragile infant entering the outside world, and the immediate physical shock of birth just hits them, and the physics are completely working against them.
Oh, Kylie.
They have a massive surface area to weight ratio. They have almost no insulating fat, and they lack brown fat, which full-term babies use as a kind of internal heat generator.
Right, the built-in furnace.
Exactly. It reminds me of trying to heat a house in the dead of winter where all the doors and windows are wide open, there is zero insulation in the walls, and the furnace is completely broken.
That is a perfect analogy.
Why does a drop in room temperature trigger such a catastrophic collapse in these babies?
Because it forces them out of their neutral thermal environment, or NTE. That is the exact super narrow temperature zone where an infant's oxygen and calorie consumption are at their absolute minimum, yet their core temperature remains stable.
Okay.
So when a preterm infant is exposed to standard room temperature, they instantly experience severe cold stress. Since they don't have that brown fat furnace you mentioned, they try to conserve heat the only way a biological organism can,
do this.
by wildly increasing their metabolic rate.
So they are burning up their incredibly limited stores of calories and oxygen just to shiver.
Well, they don't even have the muscle mass to shiver, effectively.
Wow.
Yeah, they are just burning cellular energy at this totally unsustainable rate. And that cascade is brutal. I mean, burning those calories plummets their blood sugar. Burning the extra oxygen leads directly to hypoxia.
They're basically suffocating themselves trying to stay warm.
Exactly. Without enough oxygen, The body is forced into anaerobic metabolism, which floods their tiny system with lactic acid and causes severe metabolic acidosis. A slight breeze in the delivery room can completely overwhelm their physiology.
Which perfectly explains why getting oxygen into immature lungs is the immediate next hurdle. If cold stress burns oxygen, they need to replace it fast. But preterm breathing mechanics are wild.
They really are.
A normal newborn breathes maybe 30 to 60 times a minute. Preterm infants do this thing called periodic breathing, where they might just stop breathing for 10 seconds, which the text says is somehow normal for them.
Right. It's normal until it's not. It crosses into true apnea when they stop breathing for 20 seconds or more, or when even a short pause makes their heart rate crash and their skin turn blue.
That sounds terrifying.
It is. That indicates a severe systemic lack of oxygen.
And this brings us back to that wild paradox we started with. When they stop breathing, the modern resuscitation protocol feels entirely backwards. Like I said earlier, if you are suffocating, pure oxygen seems like the obvious answer. But the standard is to resuscitate these tiny infants with 21% room air, just standard room air. How does that possibly carry enough oxygen to save a failing lung?
Well, you'd assume pure oxygen is the silver bullet. Right. But we've learned the hard way that 100% oxygen is highly toxic to immature tissues.
Toxic.
Yeah, delivering high concentrations of oxygen causes intense oxidative stress. It creates free radicals that literally shred cell membranes, and it can actually increase the infant's risk of dying.
And it specifically damages their eyes, right? The text details how giving too much oxygen causes the blood vessels in the retina to grow completely abnormally.
Retinopathy of prematurity, yeah.
Right, which can detach the retina and cause permanent blindness.
That's the tightrope the clinical team walks every day. The goal is to give just enough oxygen to keep their blood saturation in a very specific, targeted range, usually between 90 and 95%, never a full 100.
Wow.
But, to even get that room air into the bloodstream, you have to deal with the alveoli, those microscopic air sacs in the lungs.
Right. Babies born under 28 weeks don't produce enough of a substance called surfactant. I'm trying to picture this mechanically. If the lungs don't have surfactant, the sacs just physically stick together when they exhale.
Yes.
Sort of like trying to pull apart a wet balloon. You'd need some kind of powder or detergent to break that surface tension?
That's the exact mechanism. Surfactant acts as a biological detergent. Before we could manufacture synthetic surfactant and deliver it directly down a tube into the infant's trachea, respiratory distress syndrome was a massive cause of infant mortality.
Because those wet balloon walls would just fuse shut.
Exactly. Now we coat those immature lungs with this detergent, and it instantly changes the lung compliance, allowing the sacs to slide open with minimal effort.
But even with surfactant, a lot of these babies still need ventilators. And the machines are mind-blowing. High-frequency ventilators don't just breathe for the baby.
No, they don't.
They deliver anywhere from 300 to over 900 tiny, rapid puffs of air per minute. That doesn't even sound like breathing. That sounds like a hummingbird's wings vibrating inside their chest.
It does, and that rapid vibration is highly intentional. If you use a standard mechanical ventilator to push a normal-sized breath into a premature lung, the physical pressure can blow a literal hole in the fragile lung tissue.
Oh my
We
God.
call that barotrauma. So the high-frequency ventilator keeps the lung constantly gently inflated and just vibrates the oxygen across the membrane.
And if their lungs are failing because the blood vessels are clamped shut, they use a gas called inhaled nitric oxide to instantly relax the vessels. But if all of that fails, the text brings up ECMO, which is basically a modified heart-lung bypass machine.
It is, but ECMO carries a terrifying catch for this specific population. The text strictly notes it is contraindicated for infants under 34 weeks gestation.
Because the machine requires heavy blood thinners to keep the plastic circuits from clotting.
Yes. If you put those heavy blood thinners into a baby that premature, their fragile blood vessels just cannot handle it. And they will almost certainly suffer a massive, catastrophic hemorrhage in the brain.
Wow.
It's a brutal limitation of the technology.
So consider the reality of the baby's experience here. You've got the oxygen and these vibrating ventilators keeping them alive, but the very machines providing this life support introduce a brand new invisible threat, which is sensory overload and pain.
Yes, the NICU is a profound sensory paradox.
It's a highly hostile macro environment for a developing nervous system. An incubator, just by itself with its motor running, produces a constant hum of 50 to 75 decibels.
And the text points out that continual noise at 85 decibels can cause permanent cochlear damage and long-term language deficits. Plus, their eyelids are so underdeveloped they are literally translucent.
Right. The bright hospital lights cut right through to their retinas. But I really want to pause on the pain aspect, because there used to be this very persistent misconception, and honestly, you still hear it today sometimes, that babies, especially premature ones, don't really feel or remember pain because their nervous systems aren't online yet.
Yeah, that misconception is genuinely one of the darkest chapters in medical history.
How does a nurse confidently push for heavy pain relief, like fentanyl, when the patient is chemically paralyzed on a ventilator and can't even cry?
Well, the text is definitive on this.
Yeah.
It is fundamentally unethical to ignore neonatal pain. Just because an infant is chemically paralyzed and cannot thrash or scream does not mean their nervous system isn't firing in absolute agony.
But if they can't move, how do the nurses actually measure the pain?
Through highly specific, validated observational tools, they monitor for physiological crashes, so sudden violent spikes in blood pressure or plummeting oxygen levels, and they look for microexpressions.
Like what?
A specific tension in the forehead, called a brow bulge or a tightly squeezed eye, that might be the only visible indicator that an infant is suffering.
And the consequences of ignoring that suffering are terrifying. The text explains that these babies have a long-term memory of pain.
They do.
Repeated noxious stimuli like constant heel pricks for blood draws or the insertion of breathing tubes can physically rewire the preterm infant's nervous system.
Yeah, their neural networks actually grow denser and branch out aggressively in response to pain, creating a heightened pain sensitivity that lasts for their entire life.
Which is why survival is only half the battle. The ultimate goal is protecting the brain's architecture. That's the foundation of what they call developmental care.
Exactly. Caregivers actively fight back against the environment. They use cycled lighting to simulate a natural day and night rhythm. They throw heavy covers over the incubators to muffle the sound.
And they use facilitated tucking, right? Manually holding the infant's arms and legs in a tightly flexed boundary so they feel contained, simulating the walls of the womb. I was amazed to read that even non-nutritive sucking, like just letting them suck on a pacifier, visibly improves their blood oxygen levels.
It's wild.
And they give them drops of oral sucrose, basically sugar water, right on the tongue, which acts as a literal, measurable pain reliever before a procedure.
Right. And don't forget, kangaroo care.
Oh, yes.
Stripping the baby down to just a diaper and placing them bare, skin to skin, on a parent's chest. We often talk about it like it's just a nice bonding exercise, but it is a potent clinical tool.
Truly.
The data shows kangaroo care actively maintains the infant's thermal stability better than some incubators, and it significantly blunts their physiological pain response during procedures like heel sticks.
It's incredible to think of human touch as a prescribed medical intervention. But despite all of this protective care, the massive stress of the environment and the blood pressure swings we talked about, they trigger severe internal battlegrounds.
They really do.
Let's look at the brain first. There is a fragile network of blood vessels deep inside the premature brain called the germinal matrix.
And because the preterm infant completely lacks the ability to auto-regulate their blood pressure the way you or I do, any sudden spike from pain, from cold stress, or even just having their diaper changed.
Wait, just a diaper change?
Yeah, it hits those tiny, underdeveloped vessels like a tidal wave, causing them to rupture.
And that blood spills directly into the ventricles of the brain. That's germinal matrix hemorrhage, which leads to outcomes like cerebral palsy or severe hydrocephalus.
Exactly.
But while the brain is under constant threat from blood pressure, the gut is fighting a completely different war against an inflammatory disease that literally causes the bowel tissue to die and perforate.
Necrotizing enterocolitis, or NECC.
Right. It carries a horrifying 50% mortality rate in these micropreemies.
Yeah, the gut necrosis is incredibly complex, but the text identifies a clear triad of causes.
Okay, what are they?
First is intestinal ischemia. When the baby experiences hypoxia, the body desperately shunts blood away from the gut to save the brain and heart, leaving the intestinal tissue starved and damaged.
Just like the fetal growth restriction we talked about earlier.
Exactly the same principle. Second is bacterial colonization by aggressive, harmful bugs like Klebsiella or E. coli.
Yeah.
And third is the introduction of standard formula feeding.
I want to zero in on that defense mechanism because it's fascinating. If you picture the preterm infant's entirely sterile, immature gut, like an unseeded garden, right? It is highly vulnerable to invasive weeds, which are those harmful bacteria.
Right.
How does donor human milk step in to act as the exact genetically engineered defense system to stop the gut from dying?
Because in the context of the NICU, human milk is not treated as food. It is a life-saving targeted medication. It acts as a protective epidermal barrier.
Wow.
Yeah, it physically coats the damaged lining of the gut. It delivers a massive dose of antioxidants to halt the inflammation, and it actively prevents those harmful bacterial weeds from adhering to the intestinal wall and multiplying.
That explains why they do GI priming.
Mhm.
The text mentions that even if the baby is receiving all of their necessary calories intravenously, the nurses will still push tiny, almost microscopic drops of breast milk down a feeding tube directly into the stomach.
Minimal enteral nutrition, yes.
Right. They aren't doing it to nourish the baby. They're doing it to seed the garden.
Precisely. They're using the milk to artificially accelerate the maturation of the gastrointestinal tract, creating a biological shield that synthetic formulas simply cannot replicate.
Okay, so we spent all this time intensely focused on the tiny infant inside the incubator, fighting the sheer physics of heat loss, vibrating on ventilators and literally rewiring their pain receptors.
Yeah.
But there's a whole family unit navigating this trauma, and surprisingly, the text points out that sometimes the most dangerous situations arise with babies who never even set foot in the NICU.
The late preterm deceptions, one of the biggest blind spots in maternal child health.
Yes. First, the text highlights the parents themselves, experiencing profound anticipatory grief. They are mourning the loss of the healthy, full-term, joyous birth they expected.
Right, they're grieving.
Instead, they are handed a crash course in complex intensive care, having to learn infant CPR and how to operate feeding tubes just to take their child home. But then you have these late preterm infants born between 34 and almost 37 weeks.
And they are incredibly deceptive because they often weigh around 5 pounds. They have some fat on their bones.
Yeah.
To the untrained eye, they look exactly like fully mature term babies.
Right.
Because they look so healthy, hospitals routinely send them straight to the regular postpartum unit with their mothers, and they might be discharged in just a couple of days.
It's like a teenager who just hit a massive sudden growth spurt. They look like an adult on the outside, so we mistakenly expect them to behave like an adult. But their internal decision-making, or in the late preterm baby's case, their internal organ function, simply isn't fully baked yet.
Exactly. Their size masks deep, secret immaturities. And because the clinical team treats them like normal full-term infants, their unique risk factors are shockingly easy to overlook until it's a sudden emergency.
Like what? What are we missing when we look at these deceptively healthy 5-pound babies?
Well, first, they fatigue incredibly fast during breastfeeding. They might latch on, take 3 or 4 strong swallows, and then fall fast asleep from sheer physiological exhaustion.
And the mom thinks everything is fine.
Right. The mother assumes the baby is full and satisfied, but the baby is actually starving, leading to severe, rapid weight loss. Second, just like the micropreemies, they are highly prone to cold stress.
So the temperature drops and they crash.
Yes. And third, their liver is still functionally immature, making them highly susceptible to severe jaundice or hyperbilirubinemia.
Which makes total sense why the clinical guidelines strictly discourage discharging a late preterm infant before a full 48 hours of observation. The family education piece here is just as critical as it is for the parents taking home a micropreemie on oxygen. You have to actively train parents how to spot the subtle, hidden cues of respiratory distress or lethargy in a baby that looks perfectly fine.
Which really brings the entire source text full circle.
Yeah.
Whether an infant is born at 24 weeks weighing a single pound or 36 weeks weighing 5 pounds, their survival depends entirely on hypervigilant observation.
Right.
You cannot trust the surface. You have to understand the deeply hidden, compromised physiology underneath.
It really is an astonishing journey to track. We've gone from the intense, unforgiving physics of a premature birth, where simply being exposed to room temperature triggers a metabolic collapse.
It's a lot to take in.
It really is. We've explored the counterintuitive methods of trauma response, holding back pure oxygen to prevent blinding oxidative stress. We navigated the sensory minefield of the incubator, where unmanaged pain physically alters the brain's architecture. We looked at the internal battlegrounds of fragile brain vessels and necrotic guts, and how human milk operates as a targeted biological therapy. And finally, we uncovered the hidden dangers facing the deceptively mature, late preterm infant. All of this immense effort, technology, and sheer willpower leads to one ultimate goal, which is sending an empowered, educated family home with their child.
It is a phenomenal triumph of medicine. But as we wrap up, I want to leave you with a thought that builds on what we discussed regarding the developing brain.
Okay, let's hear it.
We talked about how the extreme stress, the pain, and the sensory overload of the NICU physically rewire the infant's neural networks. But modern research is beginning to ask an even bigger question. Does that trauma leave a permanent epigenetic mark?
Oh, wow.
Yeah. If an infant's DNA methylation is altered by the extreme interventions required to keep them alive, we have to wonder, is the physiological legacy of the NICU confined to just that one resilient survivor? Or could the biological echoes of that incubator actually be passed down to their children and their children's children?
That is wild. It makes you look at every single NICU graduate walking around today in a completely different light. Until next time, keep diving deep.